with cholestasis. What is the pathophysiology of cholestasis? So I talked about that in case of obstruction to the bile flow, that is cholestasis, what will happen? Two things can happen. One, the backflow of bile salts and bile acids in the liver can damage the liver, and the other, the release of this bile salts and acids in the blood serum can cause systemic effect. So retention of bile solutes in liver causes hepatocytes function to decreases the synthetic ability of the liver. So albumin would decrease, the prothrombin time would increase, bile constituent in serum increased, conjugated bilirubin, the serum bile acids. All this will cause pruritus, hypercholesteremia, and systemic effects, cardiovascular effects, the renal effects, etc. Absence of bile salt in intestine, right? Absence of bile salt in intestine would affect the absorption of the fat-soluble vitamins. So malabsorption, steatorrhea, decreased ADEK, the fat-soluble vitamins, and release of endotoxin. So these three important impact of cholestasis will happen. Okay, and all these impacts we have to remember, and we have to let's say manage our patient keeping these things in mind. The next question which can be asked by the examiner about the how is bilirubin metabolized, right? So to remember the metabolism of bilirubin, we need to remember how the bilirubin is produced, how it is conjugated, and how it is excreted. So bilirubin production happens from the senescent red cells, the red cells which are destroyed. So the heme of the red cells, it is converted into biliverdin and then bilirubin. Now this bilirubin is insoluble bilirubin. It binds with albumin and it is taken by the liver. And now in liver, the conjugation of this bilirubin happens. This unconjugated bilirubin is conjugated by UDP glucuronine transferase. So now it becomes conjugated bilirubin. So bilirubin production has happened from dead red cells, RBCs, which releases heme. And this heme is converted into biliverdin and into bilirubin. Okay. So this bilirubin, as I said, is insoluble. So this combines with albumin in the serum, and now it is absorbed. It is absorbed by the liver. So in liver, the conjugation happens. So this unconjugated bilirubin is conjugated in liver by UDP glucuryl transferase into conjugated bilirubin. Okay. So now conjugated bilirubin, which is the water soluble bilirubin, it has been formed. Okay. Now this conjugated bilirubin along with bile salts, etc., is stored in the gallbladder and from liver, and it is released in your duodenum. So in duodenum, it is released, this conjugated bilirubin. Now in duodenum, this conjugated bilirubin is acted upon by the intestinal flora, and some of the three things happens. Some of the conjugated bilirubin in duodenum, they again go into unconjugated bilirubin form. Some gets converted into urobilinogen, which is excreted through urine, and some into stercobilin, which gives color to which is excreted through stool. So urobilinogen through urine and this stercobilin through stool, and unconjugated bilirubin enters the enterohepatic circulation. Okay. So in case of any problem, overproduction of bilirubin, right? Overproduction of bilirubin, there is a capacity of liver to conjugate, would cause increase in unconjugated bilirubin in the serum, right? Then the problem in the liver in the synthetic function of the liver, right? Problem in or absence of this UDP glucuronine transferase enzyme. This can again lead to decreased production of conjugated bilirubin, right? Due to problem in the hepatic cause of the jaundice. Then obstructive cause of the jaundice is because cause of the jaundice, unconjugated bilirubin is not going because of the obstruction flowing into the duodenum, and because it is not flowing into the duodenum, excretion is not happening, and because of the back pressure, it is getting released in the systemic circulation, and causing all the damage. So on the basis of remembering this bilirubin metabolism, we can delineate whether the problem is prehepatic, hepatic or post-hepatic. The jaundice is due to prehepatic cause, hepatic cause or post-hepatic. So some investigation would help us in this, which we have already done. The examiner can ask, how do you distinguish? So remember, if the bilirubin is mostly the raised bilirubin is unconjugated, it is prehepatic. Both conjugated, unconjugated, it is hepatic, and mostly conjugated, mostly conjugated, then it is post-hepatic. In urine, urobilinogen is present, then it is prehepatic. It is absent, then it is post-hepatic. Then urine bile salt is present in post-hepatic and maybe in hepatic, but not in prehepatic. Then urine bilirubin would be present in post-hepatic. Because of the back pressure, the conjugated bilirubin is released in the blood, in the serum. Fetal stercobilinogen would be increased in prehepatic, hepatic, but it will be absent in post-hepatic. Then some investigation would help us. OTPT will be normal in prehepatic and post-hepatic mostly. And in hepatic, it will be increased. Alkaline phosphatase would be normal in prehepatic and hepatic. It would be very much increased in post-hepatic. And prothrombin time would be normal in prehepatic, and in hepatic and post-hepatic it would be increased because it tells us about the synthetic function. So post-hepatic obstructive jaundice can cause derangement of the liver as I told you by the mechanism. Okay, so it can also affect the synthetic function of the liver, and prothrombin time can be affected. It could be raised, albumin could be decreased, so synthetic function of the liver would be affected. Okay. So next question which can be asked: what are the consequences of liver dysfunction? If the liver dysfunction is present, what are the consequences of it? So liver is your metabolic headquarter. So we need to tell in enumeration all the causes of liver dysfunction. So there would be effect on the synthetic function. So low serum protein, coagulopathy. There would be effect on drug metabolism, metabolic derangement would happen because liver is the metabolic headquarter. Then deficiency of fat soluble vitamins, increased serum cholesterol level. Then bile acids in the circulation would be released. This would produce the manifestation of pruritus, etc. and decrease in the immune function of the patient. So these would be the consequences of liver dysfunction, right? So immunity of the patient will be deranged. Important fat soluble vitamins will be absent, right? Metabolic function of the body would be deranged. Metabolism of the drug would be affected, right? And low serum protein, coagulopathy, and release of bile salt in circulation. This is an important point. Can cause systemic manifestation, which we will discuss. Systemic manifestation. And on two systems, this manifestation is more: cardiovascular and renal. So what the next question could be? What systemic manifestation? So what are the consequences on cardiovascular system? So this circulating bile salts and bilirubin, what does it do? It causes decrease in the myocardial contractility. It decreases the heart rate. It can cause bradycardia. It causes vasodilatation, and it decreases the sensitivity of the patient to vasopressors. So all this can cause hypotension and circulatory collapse in the patient. Impaired myocardial contractility, decreased heart rate, poor response to vasopressors and vasodilatation. So in patient with liver dysfunction, right, we need to restore the blood volume as quickly as possible. Blood loss should be restored because blood loss is very poorly tolerated. This we have to keep in mind during intraoperative period. Okay. Now what are the consequences on renal system? Acute renal dysfunction is very common in acute hepatic dysfunction, especially cholestatic jaundice. What could be the ARF is due to, acute renal failure is due to multifactorial causes: direct toxic effect and indirect effect due to the vasodilatation causing the reduced intravascular volume. So arterial hypotension and myocardial depression both leads to reduction in the intravascular volume. So renal blood flow would be reduced. And direct nephrotoxicity by the bile salts, endotoxin and inflammatory mediators. Both this because of decrease in intravascular volume and because of the direct toxic effect. Acute renal failure can happen. Now remember the level of hyperbilirubinemia. Higher the hyperbilirubinemia, more would be the